So can you see the screen? Okay.
Ma'am, yes, but it is white, ma'am. I think please keep the presentation open in the background. This is whiteboard, ma'am, actually.
But I can see actually.
We have a white screen, ma'am, actually.
Just one sec. Can you see now?
No, ma'am. Yes, ma'am. Now we can see.
Okay, fine.
Yes. Ma'am, please put it on slideshow. Yes, thank you, ma'am. Please continue.
Okay. Okay. So today I'll be talking about the lab diagnosis of COVID-19 current scenario. So as Dr. Tiran informed me, you have had this series before, a diagnosis of COVID-19. But believe me, when you go through this lecture, you will find that a lot of change has happened over the diagnostics for the last 2 to 3 months. Because initially when we started having this pandemic of COVID-19, there were very, very few labs who were actually capable of testing for COVID-19. And now through the journey of these last 5 to 6 months, we have seen how India has progressed in terms of COVID-19 testing. So just to brief why this testing for COVID-19 is important, let us look at the what are the classical 5 T's. So doing this test is important for testing. Number two, it is important to track, because you will like to track the positive contacts of the patients whom you encounter for treatment purposes. And again, it is a team work, means the virologist does not work alone. He works with the community medicine people and the clinical counterparts to provide this diagnosis and for the treatment of these patients. And a definite commitment at a senior level is required for tracking and monitoring the COVID-19 related diagnostics activities. So in my talk today, I will try to address these questions. Which tests should be done? What should be the time of sampling? What are the various false positives and false negatives associated with the test? The test interpretation by a virologist, and the treat quality and treat to treat variability. So by the last 2 points, what I am trying to emphasize is that the expertise of the person who is actually testing and reporting the test is very, very important, because this is not a very clear cut test in the sense that anybody can say this is positive or negative, because other than looking at some of the absolute values, there are some relative values also which you need to address, and this I will be sharing subsequently. Now, as regard to which test that has to be done, so if you looked at this figure, this shows the viral load at the time of illness, and the figures on the x-axis shows the days from the symptoms of the onset of the disease. So when you look at this, so when we say that a person has the onset of symptoms in the sense that he develops fever and other symptoms associated with COVID-19, at that time, if you do a molecular test in the form of a real-time PCR, which is usually considered as a gold standard, this means that there are high chances of picking up the patient only once the symptoms have started. But if you look at the other two extreme ends, before symptom onset or after the symptoms are relieved, your molecular test is unlikely to pick up the disease. On the other hand, when you look at the serological diagnostic test, which means the classical antibody detection, these tend to pick up only in the later part of the illness. So you have to be very sure which part of the clinical spectrum your patient is. Is he in the early part of the disease, or is he in the later part of the disease? And the testing has to be advised accordingly. So when we look at the various tests, they can be divided into the direct test or the indirect test. So by saying what are the direct tests, I mean to say that these are the tests which directly target the viral genes. Okay, so just having a brief look at the structure of the SARS coronavirus 2. Now, why I want to emphasize is because we will be gradually talking of these as we draw down the other slides. And this is important to understand, because many of you would have experienced a clinical scenario in which you would have seen that a sample has been tested positive in one lab and negative in the other lab, and that gives a lot of confusion to the person who is actually the one who has been tested. So just wanted to clarify that, since this virus has many antigens. One is the spike antigen, then the nucleocapsid antigen, the membrane antigen, the envelope antigen. So the different kits, the real-time PCR kits which are developed, they target the different antigens. So there could be some kit to kit variability among the different kits that are used. And also the antigen detection tests also target different antigens. And when we talk of now, everybody is very well versed with real-time PCR and all. But now what is actually a mystery is the antibody testing. So people are randomly going for antibody testing without understanding what are the clinical implications of this antibody testing, and whether as a lay person should you be going for it or not. So here again it is important to understand that, again, because I will be discussing these tests subsequently, that the various antibody tests, they may be directed against the various antigens. And so you may again have a variability in terms of the reproducibility of the test in different setups. So just to emphasize here, that when we talk of the spike antigen, this is the one which is the most immunogenic, and the antibodies which are targeted to these, they may be more linked to a protective antibody titer, right? Because everybody doesn't, nobody wants to know what is your antibody titer. But yes, you will like to know that whatever antibodies that you are getting, is it actually going to protect you or not going to protect you? So we will discuss it again in the further slides. So all of you by this time must be very well knowing that it's the upper respiratory samples which are mainly used for the diagnosis of COVID-19, which means the best sample, if you have to take one best sample, that is the nasopharyngeal swab sample which has to be taken. And the sampling for virology is very different from bacteriology, in the sense that the Totten swabs are not useful, and the Datron or polyester coated swabs have to be used, and these samples need to be transported in a viral transport media in one chain. But the collection of nasopharyngeal specimen is very, very important, and it needs some expertise on the part of the person who is collecting. So again, this I would want to emphasize here, that again, if these samples are not collected properly, the person is not an expert, the sample that may be taken may not be the right sample, and that may lead to a false negative result. Okay, so if one person collect, if the sampling is not proper, you will get a negative result. The other sample collection is proper, you will get a positive result. So this is again a very important point to be highlighted. And again, lower respiratory samples in case of patients who are sick and hospitalized can also be taken. So this was something which people were not aware of previously, but now I think many recognize that this is the classical viral transport medium which is required to preserve the virus. So this is collectively known as the viral transport kit. So again, what it says is this is the viral transport medium, and you have two swabs. So if you have to collect one sample, it's the nasopharyngeal sample. If by chance you don't have the expertise of collecting the nasopharyngeal sample, then you go for a nasal swab and a throat swab. So both these swabs can be collected together and put into one viral transport media. And again, I would like to emphasize that the use of personal protective equipment while collection of the specimens is very, very important and needs to be strictly adhered to. So many of you must have seen this kind of booths which have been placed outside most of the labs. So these are the mobile booths, and also mobile van facilities are also now available. And these mobile vans go from place to place. And in Chandigarh also, it is expected that these mobile van services will soon be functional. So basically, these can go to the high area or the containment zones, because the people from that zones may not be willing to come to the various centers for testing. So this kind of facilities in the containment zones can be really good. And now, since I mentioned that the use of personal protective equipment is important, and now many labs, they have started going for home-based sample collection. So this was a study done in USA in which they have shown, because every time a healthcare worker goes from his lab to the person's house and gets the sample, he has to wear the PPE, and then there's a risk of transmission of infection also while transportation. So they have compared this patient-collected tongue swabs, nasal swabs, and the mid-turbinate swabs in contrast to the nasopharyngeal swabs, and they have shown relatively good results. So this would avoid the use of unnecessary PPE. The patient can self-collect the samples, and somebody outside the door can be handed over these samples for processing. So was one of our own experiences from PGI. So this is the gingival trabecular fluid. So it is just an exudate from these drums. And here what we can see, what we have done is that we have compared this nasal and throat swab versus the gingival trabecular fluid and the saliva for the diagnosis of COVID-19. And we found that they were comparatively, though the sensitivity was lesser, but yes, they were found to be an optimum specimen for the diagnosis of COVID-19, and the viral RNA would be detected even in saliva and GCF samples. And this is important because in a community setting where you will not like to draw for nasopharyngeal swabs, then these saliva samples can be collected with a relatively ease. And this is again to highlight that the timing of collection in relation to the symptoms is very, very important. So the peak time is around the end of 2 weeks when you can expect a antibody antigen test or a molecular RT-PCR to be positive, but the antibody detection takes usually 3 to 4 weeks to develop. And again, here I would like to emphasize that there is very little literature available, and the literature is slowly evolving on antibody detection, because we don't know how long these antibodies are going to last. There are some studies which are coming up and showing reinfection, and most of the healthcare workers, many of us have been exposed. So we will like to know whether the antibodies, if, as I mentioned, whether the antibody titers that I have got after recovering from COVID infection is good enough to protect me from a reinfection or not. And as of now, it only says that the antibodies last for 3 months or so. So just having a look at the commonly used diagnostic tests. So we have already discussed some molecular based tests, which is the detection of a virus by real-time PCR, and the serological tests. So molecular tests are done on the respiratory samples, and serological tests are done on the blood samples. So the advantage of molecular test is that it can give you early detection, whereas the antibodies, they take time to develop. But when we talk of sero surveys, everybody is talking of sero surveys these days. So at that time, what we are trying to see is, we are trying to see if the population has developed antibodies or not, which simply means whether they have been exposed to the virus or not. It will not tell you whether the person has had any acute infection. So if you have to diagnose an acute infection or an infectious person and you want to isolate him, then the molecular RT-PCR is the test of choice. So there are many YouTube circulating on the concept of CT values. So what is basically this CT value? So CT refers to the cycle threshold. So when we do a real-time PCR, so there is something which is known as cycle threshold. This means actually this is a direct indicator of the viral load in the sample. Okay, so if you have so this numbers can vary from 10 to 35 depending upon the various states. So when you talk of a CT value of 10, this means that the cycle, if this is the threshold, then the positive sample crosses the threshold at suppose 10. This means that the patient has a very high viral load, because the load has crossed the cycle threshold at a very initial stage. So if indirectly what we are trying to say is that if the CT value is low, this means the patient has high viral load, but if the CT value is high, the viral load is low. But this is a general dictum which I am talking of. But in COVID era, we have seen something quite different. Even our own literature search and our own experience has shown that even in asymptomatic people, we have got people having high viral load. So this viral load cannot be correlated with symptoms. So it doesn't mean that if you have a very low CT or a high viral load, you are going to have symptoms. So it is just how your immunity behaves against this virus. So what I was talking about is, one is the conventional PCR, and this is again a real-time PCR. So PGI has recently procured this real-time PCR machine, which is a 16-channel machine. And the advantage of using this machine is that it is basically, you can make your real-time PCR faster. So conventional PCR takes around 6 to 8 hours, while in this, it can be done using this machine, which can be give you results within 1 hour. So these are GeneXpert and TrueNat machines which are doing this task. So these basically are used in cases where, I mean, you have to give a very rapid diagnosis. Somebody comes with a neurosurgical issues, or some trauma cases are there. So this is one thing which would be really useful, so that the patient can be immediately taken up for surgery. And TrueNat is also based on a real-time PCR principle also, but these two machines, they have a slight difference. Okay. So another important thing which needs to be highlighted is the use of pool testing. So what is this pool testing? So basically in pool testing, what is done is, like normally in a microbiology lab, you would process all samples singly, sample 1, sample 2, sample 3. But now in the initial part, when the prevalence in our area was less than 2%, then this is a publication from Indian Council of Medical Research in collaboration with multiple departments, and where it has been seen that when we compared, when you pool samples, there was scarcity of resources, the kits were not available. So you are just trying to see whether 5 or 10 samples, if they can be pooled and considered as one sample, will it give you the same results as single sample? Because that will help to save on the resources. And we got very good results, which we have again published in another study also. So even 10 samples pooled as one samples were given very good results, which would help to save on the resources. So this is the workflow. The samples are processed in a biosafety cabinet. There are 3 or 4 steps involved in the PCR. And again, I mean, the biosafety measures and the is a very important concern. And all PPE should be worn while handling these samples. An important thing again is a quality assurance, because in a bid to improve testing, the government of India has added so many labs in the network. I mean, in the earlier pre-COVID era, you could count the number of virology labs and the virologists on your fingertips. But now it is beyond, more than 500 labs have been established all across the country. And this has really helped to upscale the testing. But quality assurance means the time to selection of the samples, receiving of the samples, the analytical phase, and the post-analytical phase, as I mentioned, the reporting by the virologist. All these are very, very important to ensure that you generate a good quality report. So this was one mode of testing. The other mode of testing is an antigen detection test. So how does this differ from a real-time PCR is that this gives you a rapid test. Okay, so this results, as I mentioned, that gives you 6 to 8 hours, and this gives you results within 30 minutes. The conventional PCR costs around 1,200 rupees. A gene expert would cost you around 2,000, while this antigen test would cost you approximately around 500 rupees. So within, by spending just this amount of time, and by spending only 30 minutes, you can get, this is usually a very good test. But the only problem with this test is that this will give you at least, almost what is said is, the 9,400 copies should be there in the person to tell whether this antigen would be positive or not. So somebody who has a very low tropy number may be negative by antigen detection, but he may come to be positive by real-time PCR. So this is very, very important to understand. So this is the ICMR's algorithm for interpretation of rapid antigen tests. So this is the algorithm which is
Hello. Yes, ma'am, you're muted.
hello.
Yes, ma'am. Please continue. Ma'am, this is the whiteboard. Please select this slide.
Can you see it?
Ma'am, this is still the whiteboard. You'll get an option below the whiteboard for
Can you see now?
It's still the whiteboard, ma'am.
What do I do?
Ma'am, allow me to share. I'll share your presentation, and then you can continue if it is okay.
Just I brought it. I brought it. Just once. Can you see now?
Yes, ma'am. Please continue. Yes.
Okay. So what I'm trying to tell you here is, oh, hello.
Yes, ma'am. You're audible,
Okay.
ma'am.
Yeah. What I'm trying to tell you here is that so for any asymptomatic person, you can just if he is antigen negative, you can leave the person at that. But if he's symptomatic, then you have to assure that you send a real-time PCR results. So these are some of the treats which have been validated by ICMR, and again they can be divided into bedside treats versus a lab-based treats. So this particular treat, the treat number 4, has to be carried out in the lab in contrast to the others which are bedside treats. And again, antibody detection, as I mentioned, it also plays a very important role. Again, I will just, there are different methods which are available. So it could be a neutralization test, a LISA, or a automated analyzers like CLIA machines, which can be used for diagnosing detecting these antibodies. So again, this slide is a very important one as to what is the role of serology for SARS-CoV-2. And here it is important to understand that it is mainly useful for seroprevalence studies. And now all of us have heard of plasma therapy. Okay, so it is important to identify those plasma donors because it is only the COVID recovered patients who have a high antibody titers who would be actually potential plasma donors. And now we know that it's the world is racing for this development of the COVID vaccines. So how do you identify the immune response? It is only by using these serological tests so that you know that the vaccine that has been given will develop a immune response against this or not. And again, now this last point is again an indication. We have seen many patients who say that I have typically COVID and the symptoms are like that, but the PCR results come out to be negative. So again, this would be important in such patients, maybe in later point of the time, because the antibody responses usually develop after 2 weeks. So it would be important for diagnosis of those patients. But according to IDSA guidelines, the Infectious Disease Society of America, it should not be used for diagnosis of acute COVID-19 infection, and it is not a determination of whether you have a protective immunity or not. This is unlike most viral vaccines. You would agree with me that when we say hepatitis B, any titer more than 10 is protective. So there are no such correlates here. So it just means antibody presence means that you have been exposed and then you have had this disease previously. It will not tell you whether you are protected or not. And in no way, if somebody has antibodies, they should think that PPE does not have to be worn, because there are cases again of reinfections also occurring in the people who have had COVID-19 earlier. So in Chandigarh, with the help of Dr. Madhu Gupta, who is the PI, we are conducting this Covishield vaccine trial. And again, the response to these vaccines is being assessed by using a LISA platform as well as the CLIA platform, which is available with us. And again, this platform is being used to identify the population of Chandigarh who has been exposed to the virus. Because now, if we look at the current trend, people are not coming forward for testing because everybody is scared and they know that the mortality is not very high. So they would prefer to sit at home. And now, if you want to actually say that who have been infected or not, so it would be just conducting the sero surveys in the cities and finding out how many people have been infected. So these are some of the new tests which are coming up. This is a test known as Feluda, and this is a paper strip test. And the advantage is, like, this is cheaper, light antigen detection, but it is very, very sensitive, equivalent to your real-time PCR. So the antigen detection had a sensitivity of 50 to 80% only, but this has a sensitivity of more than 90 to 95%. So this would be a real, this has just been launched and it is expected to be in the market very soon, but it would be really good because it will combine the trust of antigen with the sensitivity of PCR. And this is another test, which is again Charlotte testing, which is based again on the same principle. And this is another test which is known as reverse transcriptase lamp. So again, this is been developed, and it will also be very useful because it will help in rapid diagnosis of the infections. So these are some of the rapid diagnostic tricks which are in use. And we have been talking about escalating the testing, more and more labs to be added, more and more numbers to be added. So at the same time, it was important because these kits, most of the kits for testing, they were shipped from abroad. And with the crisis and the lockdowns, India had a huge crisis of reagents for testing. So scientists from CCMB Hyderabad, they have come out with a test, because as I mentioned, for a conventional PCR, you first need to extract the RNA. But here they were able to simply heat the swab collected at a high temperature, and then this was used for directly for real-time PCR without obviating the step for the real-time for the RNA extraction, because that was also very time consuming and also led to additional usage of resources. So this is some of the things which are coming up. And then indigenous traits also came up. India developed its own traits, and these were also validated by the various validation centers, because the quality of the traits is very, very important for a good lab reporting and to ensure the quality of the results. So there were many, many traits in the market, ranging from different viral transport media to the various RNA extraction traits and to the real-time PCR traits. And all these had to be tested to ensure that these are actually manufactured as per the good manufacturing practices and they meet the quality standards. So just to share the journey of our lab, we have tested around 70,000 plus samples till date, and we have been involved as a mentoring institute. As I mentioned, that more and more labs had to be brought on board for COVID-19 testing, and so more than 50 institutes have been established in North India. And then, as I mentioned, the reagents were a big issue. So ICMR provided us with reagents which had to be transported to labs all across the North India, and we were also a part of the ICMR kit validation center. So these kits were sent to us for checking and ensuring the quality before they could come to the market. And we are also a quality assurance center for many of the labs in North India, because again, as I mentioned, the reporting may be subjective to some extent, and it is very, very important to ensure to maintain the quality of these labs. And I'm really thankful to my entire team and the faculty and the staff of our department, who have been working tirelessly over the last few months without taking a single day break. And I'm thankful to the organizers for giving me an opportunity to share my work. Thank you so much.
Thank you so much, ma'am, for this very informative and a comprehensive session on lab diagnosis. I'm sure our participants would have got a lot of information regarding that. Now moving on to the next session of the webinar, I would like to invite Madam Tanuja. She's a project coordinator from Tata Institute of Social Sciences to take a session on psychosocial support for those on frontline during COVID-19 pandemic.
Thank you so much for having me. And this is a bit of a shift that I'm making from the conversation that was happening, whereby I'm going to talk a little bit about mental health and well-being and psychosocial well-being within the pandemic, specifically with the focus on healthcare, mental health care professionals, or support staff who have been working tirelessly non-stop since many, many past months. My name is Tanuja, as ma'am shared, and I work with ICOL, which is a national level technology assisted mental health psychosocial support service. I'm a trained counselor and psychotherapist by training, and we are a project of the Tata Institute of Mumbai. I'm representing a service which is called Swasthi, which is a dedicated helpline for all the healthcare professionals and allied support staff who are working for the pandemic for their emotional support. So just to sort of shift gears a little bit, and I won't take a lot of time, but to just talk a little bit about while in these past few months, I think it's really has been a very, very huge challenge, particularly for healthcare staff. There have been different aspects through which people have had to tackle, staff have had to respond to, be it at a personal level, but at the same time, of course, clearly at a professional level. This includes experiencing extensive amount of fear, anxiety during the pandemic, especially because there is just so much ambiguity about the protocols, so much ambiguity about even in terms of the modality, protocol of treatment, or be it caregiving, or be it sort of supporting, or be it in, I think I was hearing the updates that ma'am was sharing with regards to testing, and how there have been a lot of developments. And I think being sort of keeping tabs on that, and at the same time the uncertainty to not know what comes next, can be something that can has been seen impacting a lot of healthcare professionals. Of course, there's stigmatization in terms of family members who are discriminated against. We have seen so many cases of doctors, nurses, medical professionals, ASHA workers who have been banned from entering villages when they're doing these surveys, or when they're doing contact tracings, or landlords who have said that you can't visit the society if you're going to a hospital, and so on. And I think the stigmatization as well as the discrimination while trying to be able to do your work is something which is a very real fear, and I think that's something that has been seen a lot in the past few months. Of course, overwhelming feelings of helplessness being around. I think the consistent load, I think we talk a lot about that, you can't afford to be really sort of, you can't afford to not be alert at any point of time. So day in and day out, the mind is stressed, the body is stressed, and is on high alert, and therefore which also a lot of times leads to a lot of feelings of helplessness, because we've seen that professionals are doing everything that is possible within their capacity, and yet unfortunately for a lot of reasons it seems like it is not enough. And I think those feelings, when internalized, can lead to a lot of feeling of loneliness, feeling detached, isolated, or even sad. Of course, there is a lot of disconnect in terms of how infrastructure is available, or even remuneration for that matter. We work very closely with different departments in Maharashtra and other parts of the country, and especially this is something that has been so it's not like that healthcare professionals have not wanted to work or be there, but at the same time the lack of gear, the masks, the sanitations, facilities in hospitals, or adequate medical facilities, even for field staff who is working in the field, or who is doing the contact tracing, has been a great point of distress. Of course, at the same time, consistently being exposed to narratives of misery, or narratives of helplessness, leads to a lot of vicarious traumatization, leads to a lot of compassion fatigue. No matter how much you extend yourself to your work, sometimes unfortunately that has been seeming not enough in the past few months. And this impact on the emotional well-being is also very clearly seen through other psychosocial physiological impact, right? Say headaches, body aches, sleeplessness, lack of appetite, changes in sort of feeling withdrawn or not being interested in things that you'd usually sort of involve yourself in emotionally, or feeling detached from your loved ones, from your friends, and so on. Of course, the pandemic has been something which has been really particularly difficult for people who may already been struggling with issues of depression, anxiety, OCD, or any other physical health conditions. We run a helpline for healthcare professionals whereby doctors, nurses, ambulance drivers, lab technicians, they reach out to us from across the country, and many of them have reported concerns related to their marital, intimate relationships, are feeling disconnected with their children, with their family members, even as a professional, sometimes feeling that I may not be doing enough, or what more can I do, or what if I do something wrong, the moral guilt of having to take decisions which are really life-changing decisions for your patients. We even hear a lot of narratives that doctors and professionals share about that. For me and my work, the relationship that I share with my patient is a very big motivating factor. And when I'm wearing a PPE kit, and when I have hundreds of patients to cater, I do not really have a luxury to even ask the patient that how they are doing, or ask them something specific, which I would have liked to do so differently in any other circumstances. And all of these sort of personal as well as professional concerns have been sort of now reflecting in terms of a burnout, or a lot of, sometimes in some particular cases, even professionals feeling vulnerable. We are even seeing some cases which are coming in from abroad and other countries, whereby the rate of suicidality and even self-harm tendencies within healthcare professionals have seemed to have increased. And I think all of this sort of really highlights the need to focus on mental health and building that psychosocial support for doctors, healthcare professionals who are working tirelessly since all of these months. So I just want to now talk a little bit about why care important, and how does burnout or how do all of these things reflect in our work? And I will also request, if a lot of these symptoms that I'm talking about, if you are recognizing those in yourself or anybody, your colleagues or those around you, please be sort of alert about these symptoms, and please sort of take this as a call as also that, okay, there is some investment that needs to be made for your emotional well-being. And I know, as I'm saying that it might seem like a luxury, that if you don't have 8 hours to get good enough sleep, then finding the time off to sort of take care of yourself emotionally might seem something, not feasible at this point of time, but it's something which is really, really crucial. So there are feelings of exhaustion, feelings of feeling consistently tired. So even if you sleep for 8 or 10 hours, you don't feel like you've had good enough sleep. Feeling isolated, feeling cut off from other people due to various reasons, be it discrimination, be it stigma, be it the fact that other people do not understand what you go through when you enter the department or you enter your clinic and when you start working with patients. Sometimes it may also feel like, it will be good if just all of this just stops or all of this just ends. There may be irritability, low frustration tolerance, or consistently falling sick. These are some signs which will sort of come in terms of burnout. There are also other signs which will be related to compassion fatigue, be it hypervigilance, being consistently alert of every symptom that develops in a body, feeling hopelessness that, nothing is going to come out of it, or feeling self-doubt. Sometimes, difficulty being able to concentrate, not remembering things, poor self-care, changes in appetite, not feeling motivated enough, or not knowing why you started doing this in the first place, not being able to get good sleep, struggling with regards to relationships, sexual intimacy, or constantly feeling overwhelmed. So these are also challenges that are reflective of excess compassion fatigue, and these are also symptoms that are reflective of high levels of distress that somebody may be experiencing. So what is it that you can do? And again, as I'm saying this, I'm sort of recommending really, really brief and small things that you can probably do to find 5 minutes out of your day and investing in for yourself and your well-being. So I think one of the most important ways of taking care of yourself is building a practice of self-care. We feel, and I think especially as helping professionals, we feel really comfortable extending ourselves to take care of other people, but we sometimes we feel guilty, we feel uncomfortable when trying to do that for ourselves, right? It makes sense to do extra hours of shift in the ward because there is a requirement, but it doesn't seem, or it may seem guilty, especially in a time like this, if you are asked to take 2-3 hours extra of a break to just calm down and relax and do something that helps you. So of course, vicarious trauma is something that impacts us personally as well as professionally. Okay, and how is it that we can engage in self-care to take care of ourselves? So it's not, self-care is not something really like, you go through 6 months of exhaustive work, you take a 10 days vacation and then come back to the same. It's really doing smaller things within your day, which is not selfish at all, but really doing smaller things within your day that help you emotionally, that help you feel more connected with yourself and those around you that who are important to you, right? So what can you do to take care of yourself physically? And of course, most of your doctors and medical professionals, so I don't need to be talking about these things, but just like ensuring that you eat your 3 meals and not skipping meals, eating mindfully. Many of times, and I'm asking this question, that if I ask you that, what did you have for dinner last night? I'm sure many of us will have to wait for 2 minutes and think that what exactly did we have, because we are really working on an autopilot mode whereby we just do things and get done with them and move on. So whatever smaller times, be it brushing your teeth, be it taking a bath, try and do those things as mindfully as you can by being there in the present and focusing on them. Take time off, even if that means like taking a brief walk, taking a small nap, drinking water, or taking a cup of tea and finding a corner in the hospital or your clinic and just sitting quietly, whatever you can afford. Or even if you don't have the privacy at home, just staying in the bath 5 minutes longer than you would and just sitting and doing nothing. So take this time off in whatever ways you can. Of course, get medical care when you need it. Take time off when you're sick. Avoid working through your sickness. Also, because primarily, while it may feel like it's a luxury that you can't afford right now, but in the long run, it is something that will be really helpful. Get enough sleep. You can also focus on some sleep hygiene practices like avoiding a lot of caffeine before sleeping, or avoiding a lot of workout, or sort of keeping your bed clean, sort of associating with nicer smells, which helps also with the quality of sleep. Take care of your skin, body, especially areas which are impacted by constantly wearing PPE kits for longer hours, in whatever ways that you can. At work, what can be done? Taking smaller breaks, talk to your coworkers, talk to your colleagues, access supervision, and have conversations with them which are absolutely not related to your work or patient care. Just sort of, whatever is happening in your life, or whatever is going on, whatever you found interesting today. It's really important to build these connections for you to be able to have things in your life that feels as a source of hope and that feels as a source of calmness. Start your day mindfully, as you even if that means that identifying a ritual, that before you make a cup of tea for everybody, just make one for yourself, sit in a corner, listen to a song, have it, and then get on and do other things in your day. Identify quiet time to complete certain tasks. Consistently keep on working on, say, what are the things that I'm grateful for today, or what were the motivations that led me to join this profession in the first place. Because again, the times are such that it can be very, very challenging and difficult to remind yourself or remember these things, as you sort of go through it. Recognize that there are a lot of things that you may not be able to do as you would like to do, but at the end of the day, you're human, and it's important to be compassionate to yourself. It's important to be kind to yourself, the same way that you would be kind to your loved ones, right? If your loved ones were going through something like this, you would tell them compassionate things. You would tell them that it's okay, there is nothing wrong with this, try better the next time, it's not your fault. So it's important to sort of have this dialogue internally with yourself as well. Keep on celebrating smaller victories in whatever ways you can, that be it that the number of people that you've treated, be it the number of people that you've offered support to, and discuss those victories or discuss those smaller sort of wins with your colleagues and enjoy them, which is very, very important. That does not make you a bad doctor who's ignoring all the bad that is happening. On an emotional level, take time for self-reflection. It can mean writing down, journaling, noticing what certain experiences make you feel internally. If you'd like, you can access personal therapy for yourself. Read things which are not related to your work. It's okay to seek help. Again, I'm saying, as helping professionals, we are okay with the idea of giving to others, but we are not comfortable with the idea of not comfortable with the idea of help from others. At the same time, so identify people, places, tasks, experiences that help you feel good, that help you feel loved. Ensure and proactively seek these connections, which is something that will really, really help you. Smaller grounding exercises, like really, moving, taking physical movements, squeezing your arms, legs, walking, holding an ice cube, punching a pillow, running, dancing, creating something, coloring with crayons, ripping papers, anything, or just focusing on your breathing. These are things that really help to feel calmer. Try to identify a few days within your, few minutes within your day that will make you feel good. Try and practice self-compassion affirmation, reminding yourself that whatever good you did today, and you did all that you could. You're working really hard, and that should be appreciated. It is okay to take some time off and have fun or relax. Try and I think acknowledge all the hard work that you're doing, and try and be compassionate to yourself with regards to that. Um, I just want to end by sort of highlighting the number of Swasti helpline, which, as I said, is a helpline which is specifically offered and created, which is a free professional helpline, developed by ICOL, Tata Institute of Social Sciences, and the UNFPA. This helpline is catered by professionals who are counselors, clinical or counseling psychologists, who have a background in mental health care, and at the same time are specifically trained to understand issues that healthcare and frontline staff are going through. The helpline is completely free of cost. You can reach out on the number which is given on the screen, or you can even write an email to seek counseling services. The helpline is available from Monday to Saturday, 10 a.m. to 6 p.m. All the counselors can speak English and Hindi. However, apart from that, upon request, there are languages of Marathi, Malayalam, Kannada, and Bengali are also which are available. This is a completely confidential helpline, and the concerns that you may be experiencing, you don't need to really just talk about your work. But if anything that is bothering you, you can, be it professional, so be it say work, be it personal life, be it mental health, be it family related conflicts, be it violence, be it suicidal ideations, anything really, you can reach out to this helpline to seek anonymous and confidential support. You don't have to share your name, where you come from, what is your designation, nothing. This is a free service, so I will urge you to try and test and see if you like it. And at the same time, I will also request you to note the number down and share it with your colleagues, because if you are able to connect even anybody who really needs this service in time, I think that will be a huge kind of a support network that we can create. With this, I'll stop. Thank you so much for having me here. I'll now hand the session back over to the moderator.
Thank you so much, ma'am. I think this is really helpful, and it is actually the need of the hour right now, because people are, there has been many incidences where people have been stressed and they're facing these kind of things, but they're not able to express themselves. So I think your session will particularly be really helpful for the participants and for other population in general as well. Now, moving on to the final session for today, I would like to invite Dr. Neena Singla. She's a project technical faculty in PGMR Chandigarh to take her session on violence against women and providing care to a victim of sexual violence in the current scenario.
Thank you, Kiranji, and welcome all. Wish you all a very pleasant good
Dr.
afternoon.
Neena, ma'am, can you hear me?
Yeah, I can. You can't hear me?
You're audible, ma'am.
Yeah. I think the problem is with your network, I think, Kiranji. Hello?
Yes, ma'am.
Yeah. Thank you, and wish you all a very good afternoon. So today my topic is violence against women, and particularly sexual violence. This is a topic which is very close to my heart, and I'm really grateful to UNFPA for giving me the opportunity to talk on this subject. So this is violence against women is a ever-present thing which is at the back, and nobody wants to talk about it. And actually, it is one of the most underreported subjects, underreported incidents. So it is just the tip of the iceberg that we see, that is visible to us. I'll just...
And please put it on slide.
Yeah. Can you see it? It's on full this thing.
Yes, ma'am. Continue.
So what is sexual violence? Sexual violence, as defined by WHO, is any sexual act, attempt to obtain a sexual act, unwanted sexual comments or advances, or acts to traffic or otherwise directed against a person's sexuality using any type of force by any person, regardless of the relationship to the victim, in any setting, including but not limited to home or the workplace. So what are the various forms of sexual violence? This was just the definition. But the different forms of sexual violence which come under this are, you'll be surprised to know there are so many forms which are designated as sexual violence, but people are not aware of them. So coerced or forced sex in marriage or live-in or dating relationships, this also comes under sexual violence, which is increasing during this COVID-19 pandemic, and this has increased to a great extent all over the world. Rape by strangers, systematic rape during armed conflict, which is very common because when any army is, when there is an armed struggle, so the soft targets are the women and the children. So they are the ones who normally face this systematic rape. Sexual slavery, unwanted sexual advances or sexual harassment, sexual abuse of children, which is rampant, sexual abuse of people with mental and physical disabilities, forced prostitution and trafficking for the purpose of sexual exploitation, child and forced marriage, denial of the right to use contraception or to adopt other measures to protect against unwanted pregnancy, forced abortion and forced sterilization, female genital cutting, inspections of virginity, forced exposure to pornography, and forcibly disrobing and parading naked any person. So now you see even the denial for the right to use contraception or to adopt other measures, this is also considered as sexual violence, and forced abortion or forced sterilization are also part of this. Female genital cutting or mutilation, which is very common in some countries, though not so common in our country. This is also one of the forms of sexual violence. And this is as per the protocols given by the government of India. These definitions of sexual violence are as per that. So this is a global problem. Violence against women is treated by the World Health Organization and the United Nations as one of the greatest public health problems. And this is the most systematically practiced violation of human rights in the world. It is a global problem. Sexual violence itself is a global problem. Data from country and local studies indicate that in some parts of the world, at least one woman in every 5 has suffered. So that is a very high number. She has suffered an attempted or completed act of violence by an intimate partner, and mostly it is the intimate partner who is responsible. 1/3 of women describe their first sexual experience as being forced. This has been seen in adolescents. Many of the adolescents, they complain of this, that their first sexual experience was a forced one, and mostly it is by a family member or a person known to them. Although the vast majority of victims are women, men and children of both sexes are also known to have experienced sexual violence. So nobody is exempt and no age is exempt from sexual violence. Settings where it takes place, it can take place at home, it can take place at the workplace, schools, community. In many cases, it begins in childhood or adolescence, and many a times at the hands of a person known to the victim. So what we say is that no means no, but that is not true. It is always like this, there is always a problem with the consent. Whenever a person goes to court, that is the part where it always hangs fire, whether it was consensual or not. So if a woman says no, it means no, whether there is any proof or not. Why the surge in violence? This has become a shadow pandemic. The act of violence against women, it has taken form of a shadow pandemic during this COVID-19 pandemic, because there has been large-scale displacement of migrant workers, leading to loss of livelihood, and there has been financial stress. This has also led to frustration and violence. Violence most of the times it takes against the most vulnerable groups. Increased violence against children and family members on account of being cooped at home most of the times. Many a times it happens that the male member of the family is not having a job, but the female is having a job. So his ego cannot take it, and just to show control, this takes the form of sexual violence. Increase in sexual activity indirectly increases chances of sexual rights violations. Acceptance of domestic violence. Most of the times, people in our country at least, especially those belonging to the lower socioeconomic strata, they think of domestic violence as a normal thing. So they don't think it is anything abnormal, and they normally accept whatever their husbands are meting out to them. So stigmatizing the victim of sexual violence. The victims of sexual violence, they normally don't come out with their victimization, because they feel they'll be stigmatized and they'll be blamed for the actual violence. Perceived lower status of women in society. This is a eons long problem, because since many ages, women have been at the lower rung of society, and they have had to face this violence. And what are the barriers to seeking care? The various barriers that were already present in the society, they have increased during this pandemic. There is decreased access to healthcare and legal services that protect women from violence due to COVID-19 because of lockdowns and because of less accessibility of manpower and resources. Not enough police in general, especially female police officers, they are deficient. Humiliation at the hands of investigating officers. Many a times it is said that a victim of rape is humiliated again and again. Once she's humiliated by the perpetrator, and then again at the hands of the police, and then again at the hands of the lawyers when she goes to court. So most of the times, the victims, they do not want to come forward, limiting the ability of survivors to report incidents, further intensifying the barriers. So many times the survivors are not educated enough, or they don't have the power to go and report the incidents, or they are scared. The convictions are very few and far between, and there is no witness protection in our country. So witnesses are also, they are scared to come forward. Hesitation in reporting as they lack privacy due to confinement at home. Now, at this time during COVID-19, everybody is at home. And even if they are facing sexual violence at home itself, they are scared to come out because there is no privacy. If a girl wants to make a phone call, she cannot make it because there is everybody else inside the house. So if she accesses a helpline, the person at the other end should devise some means, some code language to ask questions and tell her to answer in that way, so that you can assess whether she's undergoing any kind of violence. Conflict-related sexual violence, that is in countries which are undergoing war. This is a brutal crime and is being exacerbated during this pandemic in countries involved in armed struggle. Already underreported crime has been buried further by the coronavirus. So in recent times only, you must have come across so many incidents. I was just looking at the newspaper. I was looking at all the incidents during this period. So the newspaper is full of incidents all over the world, and more so in India. India is supposed to be the rape capital of the world. So I don't think we want to have this designation as the rape capital of the world, but that is the truth. So I was reading about so many cases in Bangalore which have increased. Then this recent Hathras case, which is in the news every day. And there have been umpteen number of cases against women and children and girls. So this is increasing, and this has happened because of the COVID-19. In fact, the National Commission for Women has brought out a data in the very beginning of the COVID-19 pandemic in April, which said that there has been almost 100% increase in reported cases of sexual violence or domestic violence. What are the consequences of intimate partner violence? Most of the times during the pandemic, they are cases of intimate partner violence. And this has led to so many health impacts. Women exposed to intimate partner violence are more likely to suffer from problems. They are twice more likely to have depression, twice more likely to have alcohol use disorders, 16% more likely to have a low birth weight baby, and 15 times more likely to acquire HIV, and 1.5 times more likely to contract syphilis infection or any other STD. Death and injury is 42% more, and 38% of all murders of women globally are reported as being committed by intimate partners. So you can see the extent of this problem. What are the consequences of violence? They can be fatal or they can be non-fatal. The non-fatal consequences themselves are so many that it makes a person literally handicapped. They can be physical, bruises, bleeding, internal injuries, fractures, cuts, burns, multiple physical injuries, even which may ultimately indirectly lead to death. Psychological and emotional is the most important and most common. The victim or the survivor may suffer from poor self-esteem, guilt, shame and self-blame, depression and anxiety, post-traumatic stress disorder, phobia, suicidal behavior, alcohol and drug abuse, and insomnia and nightmares. These are a few of the ones which I have just enumerated. There are so many more. So social implications are sexual violence impacts close relationships, because such people, they have a problem making future relationships. And even during the relationships that they are going through now, even those relationships, they have problems once they experience this sexual violence. Skepticism and ostracization, they face skepticism and ostracization from society. And community well-being is torn apart. This is torn apart like you see in the Hathras case. There may be so many caste alienations and so many other things. People will take sides, and because of that, the community system is literally torn apart. So financial costs to the community, caring for a person who suffered sexual violence, it leads to a lot of financial costs for the community also. So social implications are also in sexual and reproductive health. The person may suffer from future gynecological disorders, infertility, pregnancy-related complications, and miscarriage, unwanted pregnancy, increased risk of RTI, STI, including HIV, AIDS, mortality due to injuries, maternal mortality, homicide, suicide, and AIDS-related mortality. So there may be fatal consequences as well. These survivors, as we call them, we normally don't like to call them victims, because victim means somebody who's not able to make his or her own choice and who should be treated with pity. So that is why we are encouraged to call them survivors, because they can make their own choices and they can have informed choices, and they need to be treated with respect, dignity, and care, and not with pity. So we need to provide them holistic care in the form of dignified medical care, psychosocial support and care. We have to give them forensic and legal care, and we need to give them rehabilitation, reintegration into society, and help them with the financial burden of care as well. So what is the role of health sector? The health sector is the most important entry point for survivors, and this plays a pivotal role in the immediate examination and treatment of survivors. They help in providing mental health services. They help in documentation and refer to other services. Documentation is a very important part, because without documentation, the survivor doesn't have any recourse to legal action. So health providers are the first professional contact and strategically placed to identify and help women facing violence. So the first point of contact is a health provider, or an ASHA, or an ANM, or a social worker also. So these are the people who come in contact with these victims first of all. And it is very important to identify whether sexual violence has occurred, because most of the times the survivor is in denial. So a woman who comes with multiple injuries in sites that are usually covered, it is you who have to have a very high degree of suspicion index, so to suspect sexual violence and identify them. So any woman who comes with multiple injuries in sites that are usually covered by clothing, she may come alone or accompanied by police or a social worker. And in case of a child, the child may be accompanied by a parent, teacher, neighbor, or relative. A woman whose partner or relatives come with her and stay close at hand in order to monitor her. So you can see whether the relatives are acting suspiciously and they don't want her to tell any history. You can make out from the behavior of the relatives that there is something wrong. An exclusively anxious woman, a woman who has undergone sexual violence, will be agitated and anxious and restless and fearful. So, and most of the times she will be reluctant to provide information about how she was injured. There may be previous history of psychiatric problems such as depression, substance abuse, or suicide attempts. And there may be history of repeated accidents. Repeated accidents may be because of repeated acts of sexual violence or repeated acts of any kind of violence, or there may be fresh injuries to the breast, genitalia, or abdomen. A woman who tries to conceal the identity of the perpetrator, most of the times the women are afraid to tell the identity of the perpetrator, and they will not reveal it. So you have to be very subtle, and you have to be very sympathetic in order to gain the confidence of the woman, so that she reveals the identity of the perpetrator. Brought in a semi-conscious or unconscious condition, she may be brought in unconscious condition, tendency. And most of the times they have a tendency to get discharged against medical advice. They want to run away from the hospital as soon as possible. There may be a delay between injury and treatment and timing of report. And most of the time they report to the hospital at the time of, at night time, generally between 11 p.m. and 5 a.m. How do you tackle a survivor who does not acknowledge violence? Like, she is not telling on her own that she has suffered violence. Then how do you tackle such a survivor? You cannot pressurize such a woman, and you cannot force her to tell you anything. So you need to make her feel comfortable and give her time to decide whatever she wants to share. You can give her information, and you can tell her what all services are available in case she decides to avail of them at a later date or as an afterthought. Provide information on the effects of violence. You can counsel her that what are the effects of violence and how it will affect her life and her children's life or anybody who's near and dear to her. Offer her a follow-up visit in case she chooses to disclose something during her next visit. In my experience, many a times I have come across patients who come with injuries, and initially they will make some excuse or the other. And then later on, they will refuse to file a case. But then later on, after 1 or 2 days, then again, they'll come and file a rape case. So this is a very common feature. So you have to provide the first line of support, because the survivor is coming to you first of all. So first line of support is your responsibility. What we need to do is to listen to the survivor with empathy and without being judgmental. We have to identify the needs and concerns, and it has to be all emotional, physical, social, and practical needs. Everything has to be taken into consideration in order to give proper treatment and also to rehabilitate the person. So validate what the survivor is saying and assure her that she's not to be blamed for whatever has happened to her. You need to validate whatever is she's feeling and tell her that this is normal to feel this way, because it is she who has been violated and it is not her fault. So she is not responsible in any way for what has happened to her. So that is the most important thing to tell a survivor. Otherwise, most of them, they come with a sense of guilt. So this is what we have to do first of all. Enhance the woman's safety by discussing plans to protect herself. They may be fearful of their safety because many of them are repeat offenders, so they do not want to go into the same environment again. So you have to see how you can give them a safe environment and where you can put them up and who you can hand the woman to. So you want to protect herself from further harm if the violence reoccurred.
Dr. Neena, I'm sorry to interrupt, ma'am, but I think we are running short of time.
So, okay, I'll make it a little fast. So yes. What are the general principles for dignified medical care? The general principles for dignified medical care are a rights-based approach, which should be gender sensitive, and and there should be no discrimination on the basis of caste or economic background. It should be survivor-centered, culturally and age-appropriate services. Perpetrator accountability should be there, informed consent, maintaining privacy and confidentiality, which is very important, because many a times when the survivor comes to the hospital, she'll be sitting in a crowded OPD with no privacy or confidentiality, and which is against the rules. As per the rules of medical legal examination, such a person has to be taken to a separate room and examined there. Access to information and counseling, ensure safety and immediate treatment, provide immediate psychosocial support and linking for psychosocial counseling. Ensure appropriate referral. So detailed history with subtle prompting is very important. Seek informed consent, use language that is appropriate and relevant to local culture. Give survivors sufficient time to open up and talk. Look for signs and symptoms of trauma. Violence does not always leave signs of injury. It may lead to several other physical, psychological, and behavioral problems that are serious and need to be treated. They may present with symptoms of extreme anxiety, agitation, depression, PTSD, or sleep disorder. And since some of them might have suicidal tendencies or self-harm tendencies. How do you manage them? Alcohol, they might have alcohol or other substance abuse also. So these are different presentations with which they might come up. They can come up with presentations in almost, they can complain of anything related, which may be unrelated to the sexual violence, but actually it is a result of the sexual violence. How do you elicit history of violence? You may ask indirect questions or direct questions, which have to be subtle, and you can ask roundabout questions, like many women experience problems with their husbands, partners, or people they live with, and it is a very common feature. And do you feel the same? Similarly, has someone at home or outside ever threatened to kill you? Does your husband or partner try to control you or physically hurt you? In case of a child, you can ask about appropriate touch by a family member or inappropriate touch by a family member or a stranger. Examination and treatment of survivors. Examination should be done as per national medical legal guidelines for survivors of sexual violence. Relevant samples should be collected carefully using the safe kit, maintaining a chain of evidence. Undertake medical legal documentation. Provide medical care, appropriate treatment of injuries, including pregnancy prevention and post-exposure prophylaxis. Provide psychosocial support, counseling or referral to mental health specialists, and link for legal support. So these are the guidelines and protocols which Government of India brought them out in 2014. This is a very comprehensive document. You can get all the details from this. A detailed documentation of history examination and it is medical records is very crucial. Evidence in court of law and a medical legal documentation should be done in cases. What is the importance of psychosocial support? Pain of victims of sexual assault is often poorly understood and empathized. Services generally are limited to medical legal services, and survivors in the long term are likely to have serious psychiatric problems, which can lead to major depression, alcohol and drug abuse. Childhood sexual trauma can lead to mental health problems later on in life. It is important to identify psychological distress and provide specialized structured interventions with psychological support. Important for victims to have their story believed, and therapies must be tailored to individual circumstances. What is the type of psychosocial support? Early intervention, helping individuals through their initial reactions to assault, can reduce or even prevent more severe psychological distress. So intervention has to be very early. Help the survivors understand that their reactions are normal, aid survivors in taking control by making their own informed choices, coordinate access to referral resources and safety, assess for suicidal tendencies, tackle issues of self-blame and guilt, and discuss disclosure to family and friends who can support them, recommend counseling and follow-up. So referral linkages to support a survivor are many. Referral within the facility or to a higher medical facility as per needs, linkages with police for protection. You can facilitate them from the hospital itself. You can either the police might come with the patient or you can call the police. And then you can help in filing FIR. Linkages and referral to counseling services, mental health specialists, child welfare committees, one-stop centers, shelter homes based on need, and provide information and help establish contact for free legal aid. So there is a one-stop center scheme where there is an administrator, and if the woman goes to the one-stop center, everything is taken care of at one place itself. They facilitate all the linkages. What are the various actions taken by the government? Criminal Law Amendment Act in 2013 widened the definition of rape and made punishment more stringent, increased jail terms in most sexual assault cases, and also provided for the death penalty in rape cases that cause death of the victim or leaves her in a vegetative state, created new offenses such as the use of criminal force on a woman with intent to disrobe, voyeurism, and stalking. Punishment for gang rape was increased to 20 years to life imprisonment from the earlier 10 years to life imprisonment. Criminal Law Amendment Act 2018 put death penalty as a possible punishment for rape of a girl under 12 years. Minimum punishment is 20 years in jail. Rape below 16 years made punishable with minimum imprisonment for up to 20 years, which may extend to imprisonment for life. So even the law is becoming more stringent after the Nirbhaya case. This was a new criminal amendment, the new amendment which was brought out in the rape laws. Government has also a compensation scheme for women victim survivors, in which there are 13 categories. So they provide funds for compensation to the victims or their dependents who have suffered loss or injury as a result of the crime and who require rehabilitation. So the government helps in rehabilitation. In case of rape and unnatural sexual assault, the victim would get a minimum of ₹4 lakh and maximum of ₹7 lakh as compensation. Victim compensation scheme helps victims to overcome their adverse misfortunes and cope up with the damages and injuries caused. So with this, I conclude my presentation. We need to stop violence in all forms. So, and we must help the victims. We must help them to come back to a normal life. So with that, I'll say thank you.
Thank you so much, ma'am, for such an informative session. I think it is very important to identify and to help victims of violence, survivor of sexual violence, because I think the only way out from this problem is communication. If we can establish a good communication with the person, I think many of the situations could be solved like that. Okay. So, ma'am, we have some questions, and I think we will move on to the question and answer session. Dr. Mini, ma'am, are you there? Can you hear us?
Yes, I'm there.
Yes, ma'am. So, ma'am, first we'll take questions regarding diagnosis. There is a question in the question answer box that is COVID-19 test needed for person who is dead, and is COVID-19 transmitted from person from a dead body?
Okay. So as of now, as per the guidelines, what is being going on is that every dead body before being released is being asked for a COVID test. So the chances, because it all depends, and for these bodies also that are being released from our hospitals also, they are actually, they usually don't go home again because of the risk of transmission only. Whatever percentage may be low, but the risk entirely cannot be ruled out because there are so many things about this virus which are actually coming up. Earlier it was said that there is no airborne transmission, no aerosol transmission, and slowly these things also came up. So at this point, to say entirely that it is very safe to handle, so it is not there. But yes, the risks can be minimized in the sense that what they say is that the body can be packed in a double layer bag, and then that can be sprayed with hypochlorite. But the theoretical risk definitely exists. So this thing needs to be taken care of. So it's better to do a COVID positive test. And but ideally, even if you don't do a test, but these are the religious sentiments attached beyond it. Because right now, if you say that COVID test is negative, the person then safely take the body home. So this is the issues. But otherwise, if it is negative, you can usually take the body home. But if it is positive, then you need to, take all the precautions and take the body directly to the crematorium. Vanita? Yes,
Right.
please.
Thank you, ma'am. Ma'am, next question is that when a person is RT-PCR positive and asymptomatic, what test is required to do and when?
Actually, the test which I mentioned is gold standard is the RT-PCR only. So that is already done. So I
Okay.
actually, so there is nothing more to be done. If it is positive, means that the person is positive. And as per GOI guidelines, he stays at home and he does monitors his vitals, and the pulse oximeter has to be, the oxygen saturation has to be monitored. And if he is fine, he can stay in home isolation. If he feels that the oxygen saturation is dropping down, then he should report to the healthcare facility.
Okay. Thank you, ma'am. Ma'am, there's another question that does a positive healthcare worker require RT-PCR and or COVID antibody test before rejoining the duty?
So actually, as per the earlier guidelines, what was saying was that anybody who has to join these duties or to say that the person is negative, then there should be two transactive samples tested 24 hours apart, and they should give negative results in RT-PCR. But with the so much of testing and with the information that gradually came up, so what people did was that even the shedding for this virus can continue up to 60 to 80 days also. So if I turn out to be positive after 10 days or 17 days, the question is not related to the person's infectivity. What you want to know is that the person is infectious to others or not. Right? Because that is more of a concern whether I can spread the infection to you or not. So what people did is that from the people who were shedding these viruses for more than 10 days, they took the viruses and they tried to culture it in a biosafety level 3 facility. And then they found that these were actually the fragmented viruses, because PCR will continue to detect, because that is detecting just the viral RNA. So it will continue to detect the RNA for longer period of time, though the person may be actually non-infectious. So that cutoff was 10 days usually. So by 10 days, the person becomes non-infectious. And as per the ICMR, the quarantine guidelines of Government of India, you are supposed to be in quarantine for 17 days. So that gives you another margin of extra 7 days. So 10 days plus 7 days. So by 17 days, when a worker resumes by duty, is not supposed to be infectious. So that is why the guidelines were changed gradually, and then it was advised that mild and moderate cases, they do not need to be tested before joining duty. But yes, in severe cases, they do have these recommendations that a consecutive sample should turn out to be negative. And as far as antibody testing is concerned, as I already mentioned, antibody testing will not lead to any conclusion except that you have been previously infected or not. That's it. So there is no, I mean, yes, it would be done as a part of other, because people, what now literature is showing that asymptomatic persons, like you mentioned, is RT-PCR positive, but asymptomatic people, such people, they have seen that these people usually don't develop antibodies.
Okay.
So in case you are asymptomatic and you think that I have developed antibodies because I've had COVID, so you should not have that in your mind. So in that scenario, it would be good to do an antibody test and see whether you have developed those antibodies or not. Because if you have not developed those antibodies, it may mean on one hand that it was a very mild infection. On other hand, it would be that it was a false positive test. That person may not actually have been infected, but falsely it has been reported as positive, because it is such a sensitive test that false positive and false negatives can occur at any point of time.
Okay, thank you, ma'am. Another question is that, ma'am, can you give a time estimate as to when the highly sensitive and specific rapid antigen test like Feluda will be out in market or available in hospital across India?
So Feluda has actually been given DCGI approval. It has already been given ICMR approval. DCGI has given approval. Tata is developing it. I think it would take another 1 month or 2 months to be in the market.
Okay, thank you, ma'am. Thank you so much. Ma'am, next question is for you, Dr. Neena. Yes, ma'am. Ma'am, is it mandatory to inform police when a survivor of sexual violence reports to a hospital?
Yes, if it is sexual violence, it has to be reported to the police. But the person may not be wanting to file an FIR, but still you have to inform the police and make a medical legal case.
Okay, ma'am. And ma'am, another is that what is the minimum age of a survivor of sexual violence for giving valid consent for medical examination?
12 years is the minimum age. Any child of 12 years can give her consent. So
Okay.
below 12 years, you need the parents or somebody
Guardians.
else.
Okay. Yeah. And ma'am, is medical evidence present in all cases of sexual violence?
It may not be present in all cases, because the victim may be unconscious, and she may have been drugged, or she may have been under the influence of some other drug, or under fear, if she is fearful, then also. So, or if the person is using condom, or if she has taken bath or washed her clothes or changed her clothes. So you may not find any medical evidence.
Okay, right, ma'am. Ma'am, actually, there is one question in the question answer that there have been many incidences of suicide in hospital itself by the COVID patients. So, do we need to incorporate mandatory psychosocial social counseling of all patients as per the SOPs of treatment?
Yes, psychosocial counseling should be there, because a lot of patients have known to have psychosocial problems because of COVID. Because for one thing, they are isolated from family, they are isolated from everybody, and they are sitting in the hospital. And then there is a fear of having a severe form of disease, or turning into something severe. So a lot of psychological problems in the patients have been observed. So psychosocial counseling should be given.
Thank you, ma'am. These are the all questions that we have. So, ma'am, with this, this is the end of this webinar, and I would like to move for a vote of thanks. I would like to thank Dr. Mini P. Singh, Professor from Department of Virology, for enlightening us with such an informative session on COVID-19 diagnosis, the current status. I would also like to thank Dr. Ms. Tanuja from Tata Institute of Social Science for shedding some light on the psychosocial support for the frontline health workers. Special thanks to Dr. Neena Singla for her session on sexual violence and how to provide care to the victims of sexual violence. And very special thanks to all the participants who have been joining with us from the starting itself, and present there with us in this series of webinar. I would like to mention that feedback, please give your valuable feedback to us. The link for the feedback is posted in the chat box. And the certificates for these sessions will be issued to those who will be submitting their feedback to us in 1 or 2 days. That is all for the webinar today, ma'am. Thank you, Dr. Neena. Thank you, Dr. Minnie P. Singh, for joining with us. And
Thank you, Kiranjeet, for inviting us.
Yes, ma'am. And with this, I will close this webinar. Thank you.